Right. Let's unpack this. We are about to plunge into a world where surgical precision is measured in, well, microns and millimeters, really, where the difference between a patient regaining full function and suffering a catastrophic recurrence or failure hangs entirely on meticulous planning. This isn't generalized orthopedics. This is absolutely the cutting edge.
That's absolutely right. Our mission today is a true deep dive. We're looking at an immensely dense stack of operative sources, covering the most complex areas of musculoskeletal surgery. You've got oncology, highly technical spinal stabilization, complex joint reconstruction, and that micro-precision work in the hand and foot. And we're really trying to extract those non-negotiable principles, those foundational rules surgeons operate by when the margin for error is, well, effectively zero.
Yeah, and the source material is authoritative, isn't it? Drawn from clinical practice guides, surgical textbooks, highlighting procedures that demand a level of certainty few other medical disciplines require. And nowhere is that zero-tolerance policy more intense, I think, than in our first section, dealing with musculoskeletal tumors.
You know, the initial steps in diagnosing a tumor are arguably the most critical. They really determine the patient's long-term outcome. If the diagnosis is flawed, or maybe if the initial biopsy technique compromises the surrounding tissue, the entire possibility of limb salvage can be jeopardized right from the start.
Tell me more about that. I know the first rule is called the contamination rule. For someone listening, maybe learning this, why is the biopsy itself considered such a risk factor?
Well, because the process of inserting a needle or making an incision to sample tumor tissue, it necessarily drags cells along the path of the instrument. So that path is, by definition, contaminated with tumor cells. Therefore, the contamination rule dictates that during the definitive limb salvage surgery, that entire tract must be considered contaminated. And it has to be excised in block, that means in one piece, along with the main tumor specimen. If you leave any part of that tract behind, you risk a local recurrence. It's that simple and that serious.
Okay, wow. That immediately emphasizes a crucial workflow point then. If that contaminated tract has to be removed, it means the surgeon performing the initial biopsy must be in a really close communication with, or I guess ideally, be the surgeon who will perform the definitive limb salvage surgery.
Precisely. That's the ideal scenario. The placement of the biopsy must be strategically familiar to the surgeon performing the wide resection. It has to be planned. If the track is poorly planned, say, it traverses multiple anatomical zones or it's placed far away from the planned surgical incision, you might have to unnecessarily sacrifice healthy tissue. Or you might compromise the subsequent reconstruction just to ensure that all contaminated tissue is removed.
Yeah.
You're basically planning for disposal right from the biopsy stage.
Right, planning for disposal. That's a powerful way to put it. Now, there's surprising caution related to blood management in these cases, specifically about using a tourniquet. You often use a tourniquet in limb surgery, right, to get a bloodless field. And typically you'd exsanguinate the limb first, kind of squeeze the blood out.
Yes, that's standard technique in many orthopedic procedures. Yeah. But in oncology, we have to be exceptionally careful. The source material explicitly warns against squeezing the limb. So no compression, no rolling during exsanguination before that tourniquet is inflated.
Why? What's the mechanical risk of that squeeze? It seems counterintuitive almost.
Well, when you apply compression to an already soft tissue tumor mass, you create pressure gradients. That pressure can mechanically force tumor cells, which are often loosely confined within that pseudocapsule, out of the immediate tumor environment and potentially right into the systemic circulation through the major veins. It's all about minimizing the risk of hematogenous spread through the blood, just through mechanical force. So the safest approach, the recommended one, is simply to elevate the limb, let gravity help with venous drainage before inflation, but without applying external compression.
That's meticulous planning down to the cellular level, truly. Okay, moving on to the actual incision geometry for the biopsy. The sources lay down some stringent rules about tissue planes here. What are the two absolute geometry rules surgeons have got to follow?
Rule number one is absolutely avoid transverse incisions. Those are cuts made across the width of the limb. Don't do it. They create a massive headache during the definitive procedure because they are extremely difficult, sometimes impossible, to excise completely within the necessary wide resection margins. You really need longitudinal incisions, ones that run along the length of the limb so they can be easily encompassed and removed in an elliptical fashion later.
Okay, no transverse cuts. And rule number two speaks to maintaining anatomical boundaries, right? Preventing the tumor from spreading across compartments.
Exactly. That's the deep incision rule. The incision must pass through only a single muscle compartment. That's critical. If you cut across fascial planes or those intramuscular septa, you've potentially contaminated those planes. And that means the required wide resection has to encompass maybe 2 or more muscle compartments, which significantly complicates the reconstruction later and potentially increases the morbidity, the damage of the limb salvage. And naturally, major neurovascular structures must be strictly protected and avoided. That goes without saying, almost.
Okay, single compartment. Makes sense. When sampling the lesion, where's the best spot to get tissue that will give the most accurate diagnosis? Is it the center, the edge?
You want the most viable, metabolically active tissue. So the best strategy is usually to sample the soft tissue extension of a bone lesion, or sort of the leading edge of a soft tissue mass. That's generally where the most rapid growth and viability are happening. A common pitfall, and the sources warn against this, is sampling only the surrounding pseudocapsule, that reactive rim of compressed tissue around the tumor. That area is often just inflammatory or necrotic, and it won't give you the best picture of the tumor's true malignancy grade. You have to make sure you sample beyond that rim, get into the actual viable tumor tissue itself.
Got it. Go beyond the rim. This precision extends even to bone integrity, doesn't it? If a surgeon needs to drill into a bone to sample a lesion inside, they have to think about the risk of a post-operative fracture, what's called a pathological fracture.
That's absolutely correct. If bone must be drilled, the resulting defect has to be carefully managed to minimize stress concentration. That means the hole must be round or oval, never irregular or with sharp corners. An irregular defect creates sharp corners, which act as stress risers. They concentrate mechanical forces and can potentially lead to a sudden fracture with really minimal trauma afterwards.
And why is preventing that fracture so absolutely vital?
Because a pathological fracture, just the fracture itself, could instantly preclude the option for limb salvage surgery. It's a game changer. Once those tumor cells school into a fracture hematoma, the blood clot around the break and contaminate the entire soft tissue envelope surrounding the fracture site. The necessary margin of wide resection often becomes so enormous that amputation is the only remaining viable oncologic choice. And to prevent that hematoma formation and limit potential contamination right after drilling, the hole must be plugged, usually with just the minimal amount of polymethyl methacrylate cement, bone cement.
Okay, so plug the hole. Once we achieve those clean, wide margins, often necessary for, say, stage 3 tumors or a local recurrence, the immense challenge of reconstruction begins. Let's look at the options around major joints, maybe like the knee.
Yeah, the knee is a big one. When you resect a large segment of bone around the knee, you create a massive defect, a huge gap. Reconstruction there often relies on one of 2 major approaches. You have the rotating hinge endoprosthesis. That's a complex metal and plastic device that provides both motion and stability. Or you could use an osteoarticular allograft. That's transplanted bone and cartilage from a cadaver donor. The choice between them depends on a lot of factors: the remaining soft tissue coverage, the patient's expected activity level, the risk of infection. It's a complex decision.
And for a smaller, maybe high-demand bone like the distal radius down at the wrist?
Right, for aggressive lesions of the distal radius, which is so crucial for wrist function, a common strategy is using a proximal fibular autograft. This means taking the patient's own proximal fibula that's part of the smaller bone in the lower leg and transferring it to the wrist site. It's quite versatile. It can be used to create either an arthroplasty, a moving joint, or an arthrodesis, which is a stiff fusion, depending on the tumor extent and the patient's functional goals.
I found the concept of expendable bones really fascinating places where the body can actually tolerate removal without needing a substitute.
Yeah, it's a concept tied directly to the biomechanical importance or lack thereof of certain bones. Primary resection without reconstruction is indicated for lesions in these so-called expendable bones, meaning those whose function is easily compensated for by neighboring structures. The sources usually list the distal ulna, the other forearm bone down low, the clavicle or collarbone, and the proximal fibula as key examples. The fibula, for instance, mostly serves as a muscle attachment point in the leg, and its proximal portion can be harvested without severely destabilizing the knee or ankle, usually.
Okay. And finally, in this section, what if the tumor is just inoperable, maybe because of its location deep within the spine or the pelvis?
In those really tough, inoperable, or highly morbid sites, other modalities like radiation therapy or embolization, which means blocking the blood supply to the tumor, may be used, often sequentially, maybe one after the other. However, the source material includes a specific and quite serious long-term caution regarding irradiation. There is a recognized risk of sarcomatous change. That means the induction of a secondary, often aggressive malignancy in the irradiated field sometimes years later. It's a calculated, difficult trade-off between gaining local control of the primary tumor now and minimizing that future risk.
It truly underscores the intense high-stakes calculus inherent in orthopedic oncology, doesn't it? All right, let's pivot now. We're moving entirely from the cellular and surgical precision of tumor margins to the complex mechanical engineering of the human spine, where we have to contend with gravity, alignment, and these fixed parameters.
Yeah, what's fascinating here is how orthopedic surgeons have moved beyond simply looking at, say, a single X-ray of the spine in isolation. Now it's about understanding the entire chain of spinopelvic alignment. It's really a system of fixed and variable angles that dictate whether a person can stand upright efficiently without pain or excessive energy expenditure.
Okay, let's break down those mechanics. To really understand balance, we have to start with the parameter that doesn't change after we start growing, the anatomical blueprint, if you will, which is the pelvic incidence, PI.
Exactly. PI is really the star of the show here in spinopelvic alignment. It's a fixed morphologic parameter. Once you reach skeletal maturity, your PI is set. It does not change thereafter. Geometrically, it's defined as the angle between a line that's perpendicular to the center of the sacral end plate, the top surface of the sacrum, and a line drawn from that point to the center of the bicoxofemoral axis. That's basically an imaginary line connecting the centers of the two hip joints.
Okay, that sounds a bit dense geometrically, but what's the practical clinical relevance of PI? Why should we care so much about this fixed angle?
Oh, its clinical relevance is massive. The average adult PI is around 52 degrees, give or take 10 degrees. PI is often referred to as the takeoff degree of the lumbar spine. It essentially predetermines the anatomical requirement for spinal curvature. Crucially, a patient with a higher PI, meaning a naturally more tilted or sloped pelvis, requires a greater amount of lumbar lordosis. That's that inward curve in the lower back. They need more lordosis to maintain an upright, energy-efficient posture. If they lose that lordosis due to degeneration or surgery, they'll be unbalanced forward. They can't compensate easily.
Okay, so if PI is the fixed blueprint setting the requirement, then the pelvic tilt, PT, is how the patient tries to compensate when their spine isn't matching that blueprint anymore.
Exactly right. PT is the variable angle. It reflects the body's attempt to adapt. It represents the degree of compensatory pelvic retroversion, that's tilting the pelvis backward, that the patient uses to maintain their overall sagittal balance, their side view balance. This movement, this backward tilting, is often a last-ditch effort when the lumbar spine itself has collapsed or flattened out, lost its necessary lordosis.
So PI sets the need, PT measures the compensation effort. How do these two angles, maybe along with others, define whether the pelvis is considered balanced or unbalanced?
Well, they interact with a third key measure, the sacral slope, SS. Essentially, PI equals PT plus SS. A balanced pelvis is an efficient one. It's characterized by a high sacral slope and a correspondingly low pelvic tilt. This means the patient can stand upright without excessive muscular strain. Conversely, an unbalanced pelvis has a low sacral slope and, critically, a high pelvic tilt. That high PT tells the surgeon that the patient is working overtime. They're hyperextending their hips, retroverting their pelvis significantly just to keep their head centered over their feet. It signals mechanical failure higher up, usually in the lumbar spine, requiring surgical correction to restore that proper PL lordosis match.
That mechanical understanding seems absolutely key to modern spinal stabilization. Let's move to a common degenerative issue, spondylolisthesis, where one vertebra slips forward on the one below it. When conservative methods fail, what's the preferred surgical approach these days, according to the sources?
For degenerative spondylolisthesis, the consensus preferred treatment is generally a combined approach, posterior decompression and fusion. This nearly always involves interbody support. That means placing a cage or spacer in the disc space, and rigid internal instrumentation, like screws and rods. Often, this is supplemented with a posterolateral fusion, or PLF, which is bone graft placed on the outside along the transverse processes.
And why is that multi-pronged approach preferred over, say, just doing a simple decompression without the fusion?
The rationale has really been validated in outcomes data over the years. Combining decompression with fusion and interbody support allows for optimal neurological decompression, taking pressure off the nerves. And concurrently, it provides the highest possible rate of fusion success, getting the bones to heal together reliably. And those higher fusion rates directly correlate with superior, more durable patient outcomes because you eliminate the painful motion at that unstable segment.
But fusion, by its very nature, introduces new biomechanical stresses elsewhere, doesn't it? What is the recognized drawback of this highly effective stabilization technique?
That's the main trade-off, yes. The major drawback is the risk of adjacent segment degeneration. ASD, or sometimes called adjacent segment disease. Biomechanically, doing an inner body fusion makes the treated segment extremely stiff, much stiffer than it was naturally. This increased stiffness is thought to transfer mechanical loads and stress to the discs and facet joints immediately above and below the fused level, and this can potentially accelerate the rate at which those adjacent segments break down or become painful themselves. It's sort of the price you pay for immediate rigid stability at the index level.
Right, the stress has to go somewhere. Now, before we even get to thinking about PI and PT measurements and planning complex fusions, most patients start with just simple axial lumbar pain, common low back pain. What does the conservative treatment philosophy outlined in these sources look like for that?
It's surprisingly simple, actually, and really focused on rapid mobilization. For isolated axial lumbar pain, where there's no acute neurological deficit like leg weakness or numbness, initial management should be extremely brief rest, maybe only 1 to 3 days of limited bed rest, if any. Then, it's immediately onto anti-inflammatory drugs and rapid progression to an active, structured exercise regimen, physical therapy. The evidence strongly shows that most patients improve significantly within a relatively short window, usually 4 to 8 weeks, with this active approach. Prolonged rest is generally counterproductive.
And central to this conservative philosophy is a major imaging caveat, a real heads up that should make all of us, patients and doctors alike, cautious about rushing for an immediate MRI for back pain.
Yes, this is a point that really needs emphasis. Routine initial diagnostic studies, whether it's standard X-rays, CT, or MRI, often lack utility in the early stages of simple back pain. Why? Because the pathology they might reveal could easily be incidental. It might have nothing to do with the patient's current pain. The sources cite studies showing that imaging reveals asymptomatic disc herniations in somewhere between 20% to 36% of perfectly normal, pain-free volunteers. So if a surgeon finds a herniation on an MRI in a patient who happens to have back pain, they might incorrectly attribute the pain to that finding, even if it's not the true pain generator. This kind of bias can lead to unnecessary interventions, which is why careful clinical correlation matching the symptoms to the findings is absolutely paramount.
Wow, that massive false positive rate really underscores why the initial clinical assessment, the history and physical exam, is often far more important than just the picture taken by the machine. Okay, let's quickly shift gears to an infectious pathology. Spinal tuberculosis, also known as Pott's disease, even though it's less common in Western medicine now, it remains a huge global health consideration.
It is very significant globally, yes. It accounts for maybe 1/3 to 1/2 of all reported bone and joint tuberculosis cases worldwide. And while that might sound like a small fraction of overall Mycobacterium tuberculosis infections, maybe 2% to 3%, the severity of spinal involvement is often catastrophic if it's left untreated or treated late.
How does the disease specifically attack the spine? And what's the critical pathological distinction between how it affects adults versus children?
Typically, the infection begins in the anterior vertebral body, the front part of the vertebra, which is highly vascularized. It loves that area. It then leads to progressive bone destruction and vertebral collapse, resulting in the characteristic severe angular kyphosis, that sharp forward bend in the spine, known as a gibbous deformity. It's that classic, painful, debilitating hunchback appearance. Now, the distinction by age is crucial. In adults, the infection generally spares the intervertebral discs. Why? Because adult discs are largely avascular. They lack a direct blood supply for the bacteria to travel through easily. However, in young children, the intervertebral discs still possess some residual vascularity. There are still blood vessels there. This provides a pathway for the infection to spread easily across the disc space to the next vertebra. So in kids, the discs are not spared. This difference significantly affects the pattern and extent of bone destruction and collapse.
That's a fascinating anatomical divergence purely based on age-related blood supply differences. Okay, that wraps up our dive into spinal mechanics and pathology. Now we're going to transition to the major reconstructive challenges faced across other complex joints. We'll look at the ankle, the elbow, and the shoulder. All right, starting with the ankle. We've seen a really dramatic shift over the last decade or so in the choice between total ankle replacement, or arthroplasty, and ankle fusion, arthrodesis. Why has arthroplasty gained so much ground recently?
Yeah, if we connect this to the bigger picture in orthopedics, it definitely reflects that constant drive to reserve motion while still relieving pain. That's the holy grail, right? The data, looking back from around 2007 to 2013, show that the proportion of ankle replacements compared to fusions rose really sharply. It went from maybe 14% up to 45% of procedures done for ankle arthritis. This suggests, improving implant designs, maybe better surgical techniques becoming more widespread, and just a wider acceptance of total ankle arthroplasty TAA as a truly viable option for more patients.
But this increased usage really highlights a major surgical trade-off, doesn't it? What is the fundamental difference in outcomes between the two procedures, fusion versus replacement?
The core trade-off is essentially motion versus durability, or perhaps predictability. Arthrodesis, the fusion, provides predictable, durable pain relief and long-term stability. For many, it's a definitive, reliable solution for pain, even if it sacrifices motion. Arthroplasty, the replacement, however, aims to preserve motion, and that's highly desirable for activities like walking on uneven ground, navigating stairs, things like that. But preserving motion seems to come at a cost. One review mentioned in the sources noted that complication rates were significantly higher after arthroplasty, maybe around 54% compared to arthrodesis, which was closer to 26%.
Okay, higher complication rate. This leads us straight into one of the most critical and I found potentially unsettling findings in the source material, which is this massive discrepancy between what surgeons often report in their published data versus what large national registries show for the same procedures.
Yes, this is where we really need to apply some critical thinking, as practitioners and as patients. The data consistently shows that revision rates, the rates at which these implants have to be redone, found in large national joint registries. These registries track pretty much all procedures, regardless of who does them or where. Those rates are approximately twice as high as the revision rates reported in smaller, published sample series. And those published series are often the ones put out by the implant developers themselves, or by high-volume specialty centers. For instance, you might see a registry reporting a 21.8% revision rate at 5 years for TAA, while published series might show much lower rates, maybe single digits.
So, as someone potentially considering an advanced procedure like a total ankle replacement, how am I supposed to reconcile that? That's a huge gap. If the published literature, which might be influencing surgeon adoption and patient perception, is significantly more optimistic than the real-world all-comers data, doesn't that fundamentally challenge how we measure and communicate surgical innovation?
It certainly raises an important question about selection bias and reporting bias, absolutely. When a surgeon or a developer publishes a series, they often, perhaps unintentionally, select their best patients. They use the most rigorous postoperative protocols. They might filter out complex cases or data that doesn't meet certain stringent criteria. It's the ideal conditions report. Registries, on the other hand, capture everything. Procedures done by less experienced surgeons, procedures on patients with more comorbidities, failures due to factors maybe outside the surgeon's direct control. It's the messy reality.
So, the registry data arguably provides the more accurate real-world risk profile for the average patient, while the published data shows the potential success achievable under ideal circumstances. Shouldn't that registry data, the more realistic data, be the primary information communicated to patients during the informed consent process?
That is the essential takeaway, I think. Transparency really dictates that patients need to understand the risks associated with the procedure as it's performed broadly across the country or the world, not just in the hands of the highest volume, most experienced surgical team. The sources highlight this gap as a necessary caution. It urges the field to improve the quality and, crucially, the generalizability of published outcomes data. The high variability we still see in TAA outcomes suggests the technology is still highly operator-dependent and patient-dependent, perhaps unlike more standardized procedures like, say, total knee replacement, where outcomes are more predictable across the board.
That critical perspective on interpreting data is absolutely essential. Okay, let's move up the body to the shoulder now, starting with total shoulder arthroplasty. Component loosening is always a concern with joint replacements. Is there a difference in loosening between the glenoid, the socket, versus the humerus, the ball component?
Yes, there's a well-recognized difference. Glenoid component loosening is far more common. It's often due to eccentric loading, uneven forces across the implant, and resulting micromotion at the bone-implant interface. Humeral component loosening is less frequent, but when you do see progression of radiolucent lines around the humeral stem on X-rays, it often suggests a few specific underlying pathologies. It might indicate an indolent infection, a sort of smoldering, low-grade infection that's hard to detect. Or, alternatively, it could be a sign of polyethylene wear debris coming from the glenoid component. That plastic debris can trigger an inflammatory response that leads to proximal humeral osteolysis, basically bone being dissolved around the stem, causing it to loosen.
Okay, now when a simpler shoulder repair like a hemiarthroplasty where only the ball's replaced fails, maybe due to arthritis developing in the socket, the revision often involves moving to a device with completely different biomechanics. the reverse total shoulder arthroplasty. Why make that shift to a reverse design?
Right. A failed hemiarthroplasty often fails because of progressive glenoid arthritis, the socket wearing out, or because of critical failure of the stabilizing soft tissues, particularly the subscapularis tendon in the front. If significant instability or subscapularis deficiency is present, then revising to a reverse total shoulder arthroplasty becomes the go-to strategy. It's a very effective salvage option. The reverse design, as the name suggests, switches the ball and socket. The socket, glenosphere, is on the humerus, and the ball base plate is on the glenoid. This medializes and inferiorizes the joint's center of rotation. And that change in mechanics allows the large deltoid muscle, the big muscle on the outside of the shoulder, to function effectively to elevate the arm, even when the rotator cuff is deficient or torn. The outcomes for these revisions are quite compelling, with component survival reported around 93% at 5 years in these challenging revision scenarios.
That's impressive for a revision. Now, for standard rotator cuff repairs, the initial post-op precautions are incredibly specific and quite strict. What is the surgeon trying to protect during that early phase, and what motions are absolutely forbidden for the first 6 weeks or so?
They are protecting the integrity of the tendon-to-bone repair site. That interface is biologically weakest during the initial healing phase. It needs time to mature. So for the first 6 weeks, typically, the shoulder must be immobilized in a padded sling, often with about 30 degrees of internal rotation built in. And crucially, the patient and their therapist must strictly avoid 2 specific motions: any external rotation beyond the neutral position, and any active or passive overhead motion, like reaching up. Any significant strain on that healing construct and those particular vectors can lead to gap formation at the repair site or even a complete re-tear. So protection is key.
Okay, strict rules for rehab. And for patients who have those truly massive, irreparable rotator cuff tears that just can't be sewn back together anatomically, there's an innovative soft tissue technique being used now, right?
Yes, for certain patients with massive irreparable posterior superior cuff tears, the superior capsular reconstruction, SCR, has emerged as a viable option. The concept is that even if the torn cuff tendons themselves cannot be anatomically repaired, you can reconstruct the lost superior barrier or constraint of the shoulder joint. This typically involves using a cellular dermal matrix graft, basically a sheet of processed biological tissue, which is fixed arthroscopically between the superior glenoid rim and the greater tuberosity on the humerus. It acts as a biomechanical spacer or barrier, aiming to limit the superior migration of the humeral head relative to the glenoid, which helps improve joint stability and function, even without a functioning supraspinatus.
Interesting biological scaffold approach. Finally, let's briefly discuss the elbow. Total elbow arthroplasty can be great for pain relief, but the sources seem quite blunt. It is simply not as durable as replacements in other major joints like the hip, knee, or even the shoulder. Why is that?
Yeah, the elbow is a uniquely demanding joint. It experiences surprisingly high rotational and shear loads, even during just normal activities of daily living. And these loads are obviously much higher in manual laborers or very active individuals. The currently available semi-constrained total elbow arthroplasty designs are highly successful for pain relief and functional restoration, but primarily in low-demand patients. Think older individuals whose main goals are activities of daily living. The problem, as the sources explicitly state, is that it's just not as durable long-term as hip, knee, or shoulder replacements. It commonly fails due to excessive loads, particularly in younger, higher-demand patients. The implants, especially the bushing mechanisms connecting the components, can wear out or loosen relatively early under high stress. The technology simply can't reliably withstand the forces generated by rigorous use over decades, leading to higher rates of aseptic loosening and wear compared to other joints.
That really makes the patient selection process for elbow replacement absolutely critical then. You have to match the patient's demands to the implant's limitations. Okay, we're now transitioning to an area requiring almost micro-level precision, the hand and upper extremity. We'll start with the classic controversy and nerve surgery timing.
Yeah, if we connect this to the bigger picture again, nerve repair timing really exemplifies a fascinating conflict. It's where findings from the laboratory under ideal conditions sometimes clash with historical, real-world surgical observations, especially from wartime injuries.
Let's define the 3 main categories of timing first. You have primary repair, done right away, within maybe 6 to 12 hours of the injury. Then delayed primary, usually within the first 2 to 2.5 weeks. And finally, secondary repair, which is anything after about 2.5 to 3 weeks. Logically, you'd think immediate primary repair would always be the best approach, wouldn't you?
Experimentally, yes. In the lab, immediate primary repair is strongly supported. The tissue ends are fresh, Alignment is theoretically easier, and there's minimal scar formation obscuring the view. However, historical observations, particularly from major wars where nerve injuries were common, and subsequent clinical experience often supported delaying the repair slightly into that delayed primary window. The controversy exists because delaying allows the initial wound contamination and inflammation to subside. It also allows the surgeon to better assess the true extent of the nerve injury to clearly distinguish viable nerve tissue from non-viable damaged scar tissue at the nerve ends. And some argue that waiting a short period allows the nerve endings to soften slightly, making them technically easier to handle and align precisely without tension during the repair.
So it's a bit of a trade-off then, maximizing the ideal cellular conditions with primary repair versus maximizing maybe the optimal surgical conditions for visualization and handling with delayed primary repair. But regardless of that specific debate between primary and delayed primary, waiting too long into that secondary repair timeframe clearly has devastating, often irreversible consequences, particularly for muscle function, right?
Oh, absolutely. The clinical consequences of significant delay pushing into secondary repair are very clear. The longer the delay after injury, the poorer the eventual return of motor function. This is because distal to the injury site, the axons degenerate, and the muscle cells they supply begin to atrophy, to waste away. Critically, irreversible changes start to occur in those muscle cells after about 12 months of denervation. Beyond this threshold, roughly a year, even if the nerve is successfully repaired and manages to reinnervate the muscle tissue itself has often been replaced by fat and fibrous tissue. It simply cannot regain meaningful contractile function. Sensory recovery seems to have a slightly longer window. Sometimes useful sensation return has been observed even up to 2 years after repair, but motor recovery is much more time-sensitive.
Wow, a 12-month clock ticking on muscle viability. Beyond the muscle atrophy itself, what other negative anatomical changes happen while you're waiting for a secondary repair that make the surgery harder?
Yeah, delay allows several compounding negative consequences to set in. You get significant nerve retraction. The cut ends pull apart due to elasticity, which increases the gap that needs to be bridged and therefore the tension required for the eventual repair. Tension is bad for nerve healing. You also get contraction and scarring occurring within the endoneural tubules of the distal nerve segment. These are the tiny tubes the regenerating axons need to grow down. Scarring blocks their path. And importantly, you often see the development of severe joint contractures in the hand or limb because the paralyzed muscles aren't moving the joints through their range of motion. These contractures can prevent the muscle from having a functional arc of motion, even if some reinnervation eventually occurs.
Okay, so time is truly of the essence, especially for motor nerves. Let's move to the complex mechanics of the wrist now, specifically looking at distal radial nerve joint, DRUJ, instability. This joint allows forearm rotation. Diagnosing instability here seems to require precise evaluation of both soft tissue and bony structures.
Diagnosis is definitely multifaceted. It relies on a good history from the patient, a careful physical examination looking for things like pain, clicking, or that classic clunk of instability with provocative maneuvers. Radiographs are essential, of course, and advanced imaging is often key. CT scanning can be especially helpful, sometimes even dynamic CT scans, for assessing instability under load and for identifying subtle fractures of the sigmoid notch that's the articulating surface on the radius where the ulna sits. And MRI is becoming increasingly useful for evaluating the integrity of the crucial soft tissue stabilizer of the DRUJ, the triangular fibrocartilage complex, TFCC. Tears of the TFCC are a common cause of instability.
The real surgical challenge seems to arise when the TFCC is torn beyond repair. It's irreparable, but the articular surfaces of the radius and ulna, the joint surfaces themselves, are still in pretty good shape. You need to stabilize the joint somehow, but ideally without just fusing it and eliminating forearm rotation.
Exactly. In that specific situation where the TFCC is shot but the joint surfaces are okay, some form of soft tissue ligament reconstruction is usually necessary. The surgeon Adams, and later Berger, specifically emphasized the importance of reconstructing the actual distal radial norm ligaments, which are distinct components within the broader TFCC structure, as these are the primary stabilizers against dorsal and volar translation. The goal is to restore stability while attempting to preserve as much of the patient's pronation and supination arc, that forearm rotation, as possible.
And did that specific technique, the Adams-Berger reconstruction, prove to be durable in the long run? Do we have outcomes data on that?
Yes, there's reasonably good data. A retrospective study looking at 95 Adams-Berger reconstructions showed pretty solid long-term durability. At a mean follow-up of 65 months, so over 5 years, about 86% of the patients in that cohort achieved a stable DRUJ, which was the primary goal. However, stability often came at a price, as is common in orthopedics. While their grip strength often improved, the patient's overall range of pronosupination, that forearm rotation, tended to decrease compared to their pre-injury state or the uninjured side. It's another one of those classic orthopedic trade-offs, trading a bit of motion for durable stability.
Stability for motion, a recurring theme. Okay, finally in this section, let's turn to pediatric hand surgery and congenital deformities, specifically thumb reconstruction and congenital duplication, polydactyly. When a child is born with a severely underdeveloped thumb, a condition called hypoplasia, the solution is quite radical. It's called pellicization. What does that involve?
Pellicization is really a life-changing procedure for these children. It involves surgically transforming and meticulously moving an adjacent finger, typically the index finger, the radialmost digit, into the position and functional role of a thumb. The Buck-Gramco technique is considered the gold standard approach for this. It's recommended for severe thumb hypoplasia or for conditions like type 2 deformities, which describes the functional, though often cosmetically unusual structure, sometimes colloquially called the five-fingered hand, where there's no true opposable thumb.
And in cases where a child is born with an extra thumb, thumb duplication, or polydactyly, the Wassell's classification system seems to be the Bible for guiding surgical planning. Which pattern of duplication is the most common one seen?
Yes, Wassell's classification is essential. It categorizes the duplication based on the level at which the splitting occurs, from the distal phalanx down to the metacarpal. Wassell type 4, where the duplication occurs through the proximal phalanx, that's the second bone of the thumb, is statistically the most common pattern observed, accounting for about 47% of all thumb duplication cases. Understanding the specific Wassell type is critical because it dictates precisely how the duplication should be excised and, more importantly, how the remaining structures should be reconstructed and stabilized.
What's truly fascinating here, and it really speaks to the level of intricate detail required in hand surgery, is the pattern of muscle attachments in these duplicated thumbs. It's not random, is it?
No, absolutely not. It's highly specific and predictable, based on the nerve supply to the intrinsic muscles of the thumb. And surgeons must account for this and rebalance these muscles carefully during the reconstruction. The rule is, the ulnar innervated intrinsic muscles of the thumb, that's primarily the adductor pollicis, and the deep head of the flexor pollicis brevis, almost invariably insert onto the ulnarmost of the two duplicated thumbs. Conversely, the median innervated intrinsic muscles, the abductor pollicis brevis, and the superficial head of the flexor pollicis brevis, predominantly insert onto the radialmost thumb duplicate. So during the surgical excision of the extra thumb, the intrinsic muscles attached to the duplicated digit that is being removed must be meticulously identified, detached with a sliver of periosteum perhaps, and then carefully transferred and rebalanced onto the single thumb that is being preserved to assure proper function and stability.
Wow, that attention to specific nerve supply determining specific muscle insertion and the need for precise transfer really is the hallmark of reconstructive precision. Okay, for our final section now, we move down to the foundation of it all, the foot and ankle. We'll focus on reconstructive techniques for common issues like bunions and also for paralytic deformities.
Right, the foot is literally the foundation of our posture and locomotion. And even seemingly common issues like hallux valgus, bunions, require a detailed biomechanical strategy for correction. When correcting a bunion deformity, the choice of where to place the osteotomy, the surgical cut in the bone, is often based on maximizing the potential for healing and achieving the best mechanical advantage for correction.
And the sources seem to recommend placing that osteotomy more proximally near the base of the first metatarsal rather than more distally near the joint itself. Why is that location often considered advantageous?
An osteotomy performed at the base of the metatarsal, in the metaphysis, generally offers superior healing kinetics, for a couple of reasons. First, you're cutting through cancellous bone here. That's the spongy bone, which is rich in blood supply and healing cells. This promotes early stability, often achievable within just 3 to 5 weeks, and leads to reliable bony union, usually within 6 to 8 weeks. Furthermore, the broad contact surfaces created between the cut fragments at the base enhance the intrinsic stability of the osteotomy site. And finally, from a mechanical standpoint, small angular or translational changes made far proximally at the base translate into excellent, powerful correction of the deformity down at the NTP joint distally. You get good bang for your buck, surgically speaking.
Okay, better healing, good correction. Alternatively, for some patients, maybe those with severe deformities or significant arthritis in the big toe joint, fusion of that first metatarsalphalangeal joint is often cited as the gold standard.
Yes, Arthrodesis or fusion of the first MTP joint is frequently considered the most appropriate and reliable operation in properly selected patients, particularly those with painful arthritis accompanying the valgus deformity, or in cases of severe instability or previous failed surgeries. It is incredibly effective at correcting the underlying deformity. It's known that, on average, just fusing the MTP joint in the corrected position achieves about a 4 to 5 degree reduction in the intermetatarsal angle, the angle between the first and second metatarsals, all by itself. This inherent corrective power means that combining the fusion with an additional proximal osteotomy further up the metatarsal is usually unnecessary, except perhaps in the absolute most severe high-angle deformity cases.
That makes sense. Now, there is a major potential pitfall in bunion correction that every foot surgeon must be vigilant about: overcorrection, which can lead to the opposite problem, hallux varus, where the big toe deviates inward towards the midline. What is the specific anatomical error during surgery that is most often blamed for causing this complication?
The source material is actually very specific about this common cause. Hallux varus following bunion surgery is frequently cited as being primarily caused by the excision of too much of the medial eminence. That's the bony bump on the side of the metatarsal head. Specifically, the error occurs when the surgeon cuts too aggressively, taking bone from within or even immediately lateral to the sagittal groove on the metatarsal head. This excessive bone removal does two bad things. It can disrupt the attachment and the stabilizing function of the lateral soft tissue structures, like the adductor tendon insertion, and it removes the normal medial buttress provided by the eminence. Without that medial support, and with potential lateral tethering, the toe is then allowed to drift inward, sometimes quite dramatically, into a varus position.
It's a classic surgical mistake, isn't it? Fixing one problem perhaps a little too aggressively and inadvertently creating a new and often more complex problem. Okay, let's shift gears now to tendon transfers used for paralytic foot deformities. Let's start with what happens if just the posterior tibial muscle is paralyzed.
Paralysis of the posterior tibial muscle alone causes a really severe functional impairment. Its primary function is actually dual. It's the main inverter of the foot, turning the sole inwards, and it plays a critical role in supporting and maintaining the medial longitudinal arch during plantar flexion when pushing off. When this key muscle is lost, the foot typically collapses into a severe planovalgus deformity. That's a flat foot with the heel rolling outward, valgus. Treatment is almost always mandatory to restore function and prevent further deformity. It involves dynamic tendon transfer, taking a working tendon, often the peroneus longus from the outside of the ankle or the flexor digitorum longus from behind the ankle, and rerouting it surgically to substitute for the lost function of the posterior tibial tendon, usually attaching it to the navicular bone.
And what happens if the paralysis is even more extensive, say affecting both the anterior tibial muscle, the main dorsiflexor, and the posterior tibial muscle?
Oh, that results in an extremely challenging multiplane deformity. If you lose both the major inverter and arch support, posterior tibial, and the major dorsiflexor of the foot, anterior tibial, you essentially lose control in multiple planes. This often leads to a condition resembling a congenital rocker bottom flat foot. The midfoot collapses completely, the forefoot points upwards, and the heel points down. The foot becomes rigidly deformed and highly unstable, making walking incredibly difficult. Correcting this necessitates not just one, but often multiple tendon replacements, sometimes combined with significant bony procedures like fusions, arthrodesis, to even begin to establish a stable, plantigrade foot one that can sit flat on the ground and bear weight efficiently. The need for multiple tendon replacements really highlights the staggering complexity of trying to restore dynamic muscle balance and function when the primary motors are lost. #outro. This deep dive has truly spanned the breadth of advanced orthopedics, hasn't it? From the zero-tolerance necessity of tumor excision planning all the way to the fixed laws governing spinal posture, and then wrestling with the trade-offs inherent in modern joint replacement technology.
And what seems to define success across all these incredibly different fields is this adherence to unwavering principles. In oncology, as we saw, that principle is meticulous margin control and eliminating contamination risk at all costs. In the spine, it's about understanding and balancing the fixed PI with the variable PT to ensure an energy-efficient, balanced posture. And in joint and limb reconstruction, it's about making these deliberate, calculated trade-offs between stability, motion, and durability, often acknowledging the limitations of current technology, especially in high-demand settings like the elbow.
Exactly. We've seen the immense precision required, like, identifying exactly which intrinsic muscles insert on the ulnar versus the radial duplicated thumb digits for a successful reconstruction. But we also encountered that critical challenge regarding data transparency. The rather stark fact that National Registry revision rates for advanced procedures like total ankle arthroplasty are often running at twice the rate reported in the published surgical literature.
This raises an important question, doesn't it?
It really does. We noted that complication and revision rates captured in these comprehensive orthopedic joint registries are often double what's published in the peer-reviewed sample series, the best-case scenarios. So for you, the listener, whether you're a patient or a practitioner advising a patient relying on an advanced procedure where we acknowledge there's high variability, what is this gap? This gap between the reported potential for success and the registry reality. What does that truly mean for how we approach new surgical technologies and critically how we communicate risk? Think about the source material's intense focus on predictable, high-certainty principles in tumor excision, and contrast that with the acknowledged high variability and revision rates in something like joint replacement technology. How should orthopedics as a field reconcile the drive for high-level innovation with the need for transparent, real-world data communication to our patients?
A challenging question indeed, and an incredibly detailed analysis today of the high-stakes world of reconstructive orthopedic surgery. Thank you for taking this deep dive with us.